Good afternoon, everybody. Thank you to the organizers of the meeting for inviting me to present today. And I also thought it was a really nice touch for you all to put the Ohio State logos on all the check-in at the hotel. That made me really feel welcome. So today I'm going to talk about how to choose therapy in frontline chronic lymphocytic leukemia. Now, unfortunately, at the end, I'm actually not going to tell you how to choose therapy for CLL, but hopefully give you some strategies to decide for individual patients how you might choose among our currently available options. So these are the objectives of the talk today. We'll discuss the current standards and then some strategies for choosing. So just as a reminder, for CLL, we don't necessarily treat as soon as we diagnose a patient with the disease, but rather wait until people meet criteria for treatment, which are primarily symptom-driven. So these could be constitutional symptoms, symptoms associated with progressive tumor burden like lymphadenopathy or splenomegaly, bone marrow failure with a hemoglobin of less than 11 or platelets less than 100,000, or immune dysfunction. And this wouldn't necessarily be the first presentation of an autoimmune hemolytic anemia or ITP, but rather if the disease cannot be controlled with corticosteroids or other standard therapies. And then prior to treatment, you would want to make sure that you have appropriately genomically risk stratified your patient. And this would include the IGHV mutational status, FISH testing for specific recurrent abnormalities, a stimulated karyotype, and an NGS panel, primarily important for TP53, although of course other mutations are helpful if they're detected. So then thinking about what are all of our available options, primarily the choice comes down to a continuous covalent inhibitor of Bruton's tyrosine kinase, or a fixed duration venetoclax-based regimen. Venetoclax with obinutuzumab obviously is the one that we have the most long-term data for and is our primary standard for a fixed duration treatment. We do have increasing data on the BTK inhibitor venetoclax combinations. Currently, none of these are FDA approved. However, after I put this talk together, our second BTK inhibitor venetoclax regimen, acalabrutinib plus venetoclax, was introduced in the NCCN guidelines, and we'll talk about that a little bit today as well. So thinking about BTK, of course, this is an excellent target in CLL. It's an integral kinase in the B-cell receptor pathway, which is important for CLL development and survival. And blocking BCR signaling with BTK has, of course, been shown to have a therapeutic benefit in this disease. So our first-in-class molecule is ibrutinib. And just last year, after many years of study, we finally have the median progression-free survival for ibrutinib in frontline CLL, which is just about 9 years. And a really important consideration here is that most of these relapses are still off drug. So even at 9 years, patients are continuing to benefit often if they're still taking the medication. Of course, ibrutinib has its liabilities, and most of these are because of side effects, with atrial fibrillation seen in about 10%, but up to 15 to 20%, depending on the patient population, and hypertension also increasing in both quantity and severity as the time on treatment lengthens. So because of that, we have our two second-generation BTK inhibitors, which for the most part have supplanted ibrutinib as the covalent BTK inhibitor of choice for both frontline and relapsed CLL. These are kinase maps showing you how these drugs are different from each other. Each part of this pie here is a kinase family. Each dot is a kinase. A red dot shows that the kinase is being inhibited by the drug, and the size of the circle is the amount of inhibition. So you can clearly see ibrutinib is the least selective of these. Acalabrutinib is likely the most selective of these. And zanubrutinib functionally is closer to acalabrutinib, but sort of in the middle of these two. With acalabrutinib, we now have 6-year follow-up from the ELEVATE-TN study. And here in this study, acalabrutinib was given either alone or in combination with obinutuzumab, and then compared with chlorambucil plus obinutuzumab. And you can see at this 6-year time point, for patients treated with acalabrutinib plus obinutuzumab, 78% remain in remission. 62% of those with acalabrutinib alone remain in remission. For zanubrutinib, we now have 5-year follow-up from the Sequoia study. This was presented just last year at ASH. And at this time period, or time point, 75.8% of patients still treated with zanubrutinib remain alive and progression-free. There's a lot of data now that is kind of looking at indirect ways to compare acalabrutinib and zanubrutinib, most of which have been supported by the individual drug companies. So it's hard, and they use different types of data in their approaches, so it's hard to know really what is the difference between these two, and they probably are more similar than they are different. The only one of these I wanted to show you was actually this indirect comparison looking at acalabrutinib with or without obinutuzumab compared to zanubrutinib, specifically looking at side effects. The takeaway I want to share is that almost all of these side effects are pretty similar between these two drugs. At the top, when looking at acala plus obin compared to zanubrutinib, you can see that for this analysis, neutropenia and arthralgias were higher in patients treated with the doublet. On the bottom for the two monotherapies, again, they're both very, very similar, with a trend towards hypertension being a little bit more common in zanubrutinib-treated patients. So then the next question is, should we add an anti-CD20 to the covalent BTK inhibitors? And notably, adding an anti-CD20 antibody in this setting does not give you a time-limited therapy. It just intensifies the early treatment. We know with rituximab and with ibrutinib that the addition of this specific anti-CD20 does not improve progression-free survival. It's hard to say for sure whether this is an ibrutinib-specific phenomena or a rituximab-specific phenomena or the combination of both, though. In the ELEVATE-TN study, I already showed you the data at 6 years where patients treated with acalabrutinib plus obinutuzumab had a significantly longer progression-free survival compared to those who were treated with acalabrutinib alone. On the right, you can see some additional data from the ELEVATE-TN study broken down by TP53 status. And this is actually paired with some data from a pooled analysis of multiple studies. And basically the takeaway here is that higher risk patients do benefit from the addition of obinutuzumab, except for patients with 17p deletion, where there does not appear to be any advantage to adding the obinutuzumab. So importantly, when we think about our traditional prognostic studies, in the setting of covalent BTK inhibitors in the frontline setting, there's very little impact on outcomes with those high genomic risk categories, at least in the time frame that we're studying patients. So again, this is looking at ELEVATE-TN study for patients with or without TP53 alterations, where you see at the top there is the acalabrutinib plus obinutuzumab in patients without TP53 abnormalities. And the rest of them are all clustered together. So acalabrutinib with or without TP53 abnormalities is basically the same as is acalabrutinib plus obinutuzumab in that setting. Thinking about IGHV mutational status, again, another important risk factor in CLL, we see that pretty consistently the curve for IGHV mutated is a little bit higher than IGHV unmutated, although the differences here really are not significantly different. The same can be said for zanubrutinib. Again, here the curve in green is zanubrutinib in IGHV mutated patients, a little bit higher but not statistically different than the blue curve is zanubrutinib in IGHV unmutated patients. With zanubrutinib, we don't have comparative data with or without TP53 abnormalities, although the Arm C of the Sequoia study enrolled patients specifically with TP53 abnormalities, and you can see at a relatively short follow-up, these patients are doing very well. So what have we learned from these data? Continuous BTK inhibitors are effective and safe in frontline CLL. Acalabrutinib and zanubrutinib are preferred. The TP53 abnormalities and IGHV mutational status lose much of their predictive value in the setting of continuous BTK inhibitors in the frontline setting specifically. And obinutuzumab improves progression-free survival with acalabrutinib, except for those patients who are TP53 altered. So moving on to BCL2, the drug venetoclax is our currently only approved BCL2 inhibitor. And as you know, BCL2 is an anti-apoptotic protein, which is elevated in CLL. Inhibition of BCL2 leads to rapid cell death and can lead to minimal residual disease, undetectable states. It can cause hyperacute tumor lysis syndrome, which is why we do the step-up dosing, TLS monitoring, and stratification of patients with hospitalization for some. Our first data for venetoclax plus obinutuzumab, which led to the FDA approval, was the CLL14 study. Here we can see a median progression-free survival of 6.35 years. So this is a 1-year treatment, and then about almost 5.5-year average remission after treatment is finished. We see a pretty similar result in the CLL13 study, which looked at venetoclax plus obinutuzumab, as well as venetoclax rituximab, and the triplet of venetoclax, obinutuzumab, ibrutinib, compared with standard chemoimmunotherapy with either FCR or BR. Here we see again an advantage to venetoclax obinutuzumab versus chemoimmunotherapy. No similar benefit is seen for venetoclax plus rituximab. Here, at least at this follow-up, we don't see a lot of advantage, at least at face value, for the triplet versus the doublet. Of course, we are awaiting longer-term follow-up with these. And again, thinking about prognostic studies in this setting. So different than the continuous BTK inhibitors, with fixed-duration venetoclax obinutuzumab, we see shorter remission durations for patients who have TP53 abnormalities, as well as those who have IGVH unmutated disease. That doesn't mean that these drugs can't be considered in these patients, but I think it's important just to note that your remission duration after completion of therapy will be shorter. So what have we learned from this? Venetoclax obinutuzumab as well is an effective option for frontline disease. The fixed duration strategy does allow time off treatment, which reduces both side effects and financial toxicity. And then, as I mentioned, high-risk genomic features predict a shorter PFS. So how do we choose? And again, this is often a calculation for every individual patient, taking into account their genomic risk, their interest in a continuous therapy given for many years, their ability to do the intensive initiation with venetoclax obinutuzumab, as well as specific side effects related to comorbidities, such as cardiovascular side effects and bleeding side effects of the BTK inhibitors, and difficulty with some comorbidities like renal disease or CHF, and trying to give the hydration necessary for the start of venetoclax obinutuzumab. So importantly, we have 2 good options right now. What's next? So fixed duration regimens, of course, are of interest for the reasons that I mentioned, but venetoclax obinutuzumab is cumbersome, and as I also mentioned, less effective in high-risk disease. There are a few combinations of BTK inhibitor and BCL2 inhibitors that have been studied, which allow all oral regimens and reduces some of the burden of starting treatment because you don't need to have the infusion of obinutuzumab. Then we have triplets which have the potential to improve efficacy on the doublets that have been studied. So, of course, the first BTK-BCL2 combination was ibrutinib plus venetoclax, which has been studied in many ways. This is data from the GLOW study, which led to the approval of this regimen in Europe, although not in the United States, though it is in the NCCN guidelines. You can see here at 42 months, almost 3/4 of patients treated with ibrutinib plus venetoclax remain alive and free of progression. At ASH this past year and published last month in the New England Journal of Medicine, we saw the results from the AMPLIFY trial. This is a really exciting trial in the first study looking at doublets and triplets with fixed duration regimens and a second-generation BTK inhibitor. In this study, acalabrutinib was given either with venetoclax, or AV, or venetoclax plus obinutuzumab, or AVO. And this was compared to chemoimmunotherapy, again, with FCR or BR. You can see here that at 36 months, again, this is a 1-year duration of therapy, 83% of patients treated with AVO remain alive and free of progression. 76.5% of those patients treated with AV remain alive and free of progression. So actually fairly similar results to what we saw in GLOW. Interestingly, there seems to be a very big difference according to IGHV mutational status. Here I'm just showing you the curves for IGHV unmutated CLL. The group of patients with IGHV mutated disease, those treated with AV and AVO did fairly similar and very well at 3 years of follow-up. For IGHV unmutated CLL, the patients treated with the triplet have actually almost the same PFS as the entire study cohort at 82.8%, but those treated with the doublet dropped from, remember, about 3/4 being in remission down to 68.9% of patients being in remission at 3 years, suggesting that for patients with IGHV unmutated disease, we are going to see a shorter PFS with acalabrutinib plus venetoclax. Unfortunately, this study was conducted during the height of the COVID-19 pandemic, and the big takeaway here is that both of the arms that include the anti-CD20 antibody, I don't know if that's completely the culprit, but both of these two arms had very high rates of COVID-19 significant disease and death, with actually the triplet AVO arm having the highest rate of death from COVID. We saw neutropenia, a little bit higher, high-grade neutropenia in both the chemoimmunotherapy and the AVO arm. Importantly, though, looking down to febrile neutropenia, that was significantly higher for patients treated with chemoimmunotherapy than the triplet. Many of the other side effects are actually relatively similar across the groups, and I think it's also important, again, to note that even with this risk of death with COVID-19, the PFS curves still favor AVO and AV. So what do we know from this? BTK inhibitors plus BCL2 inhibitors offer an all-oral regimen that's effective, although follow-up is relatively short. I think, unfortunately, since we don't have head-to-head studies at this point, we don't have convincing data that venetoclax with either ibrutinib or acalabrutinib is better than venetoclax plus obinutuzumab. We are going to get some data in that regard from the ongoing MAGIC study, although that one for AV does have a MRD-guided discontinuation or extension of therapy, which will make it a little bit difficult to interpret those results in the context of the 1-year fixed-duration treatment. I think AVO may offer an advantage for IGHV unmutated patients, but at the cost of toxicity. And further data, and really especially long-term follow-up data, is needed to understand the appropriate niche for these therapies. So in conclusion, continuous BTK inhibitor with acalabrutinib with or without obinutuzumab or zanubrutinib, as well as fixed-duration venetoclax obinutuzumab, are excellent frontline options for CLL. Comorbidities, potential side effects, and genomic risk can aid in the choice for individual patients, although this often ends up being a very long discussion with patients to try to really figure out what is the most important for them and how you can use our best therapies to get them to what they would like for their goals. Acalabrutinib plus venetoclax with or without obinutuzumab also is likely going to have a role for some patients. And I think the most important thing to take away is that prospective clinical trials remain extremely important to help us determine the optimal frontline treatments for our patients with CLL. So thank you very much, and I'll take questions later on in the panel session.